Thanks for listening to the Wild Health Podcast. For the foreseeable future, you're not going to hear our normal intro or outro here. We're going to be releasing episodes very frequently as things are changing. This channel will be used for a very specific purpose. Number one, to communicate with our patients. We're somewhat overwhelmed, and the more we can communicate breaking news and recommendations from us to our patients all at once, the better. So if you're a patient, we're here for you if you need us, but if possible, please tune in here so we can both keep you up to date and conserve our time for the most critical tasks. Feel free to share this with friends and colleagues as well. Number two, we've organized as a group. We have infectious disease specialists, ER doctors, critical care doctors, and in total dozens of MDs, PhDs, and frontline clinicians who are going to be constantly evaluating the news and emerging evidence. We're then going to summarize and translate that for you here every day on the podcast. The speed of change with the circumstances will make us look foolish at times, but we're committed to pouring all of our resources and energy into doing what we can to help and make a difference. You can also follow our updates at wildhealth.com or our Instagram account at wildhealthmd. And if you're a patient, we're here for you. Please tune in here for the updates and let us know how we can help.
Hey, welcome back to the Wild Health Podcast and our COVID update. I've got with me today Dr. Mark Goodman. Mark, say hi.
Hello.
Thanks for joining me today, Mark. We're going to go through this in our typical sort of fashion. So I'm going to start off today talking about WHO and CDC changes and updates. So from the United States, today the CDC's reported 15,268 cases and 201 deaths. So that's a 46% increase in cases and a 34% increase in deaths from the previous day. So sounds bad, but overall it's actually lower than the 1.5 jump that we saw yesterday. The case fatality rate is currently at 1.32% and has been continuing to drop. I don't know about you, Mark, but my suspicion is this is likely because of an increase in testing. So we're not testing the sickest of the sick anymore, and we're seeing a continual trend downward in our fatality rate, I think, internationally.
Yeah, I think we're, at least where we work, we're still quite limited in testing supplies at this point. So I'm not sure we really have a handle on what the true number of infections are quite yet.
From the global map, Italy has now overtaken China in the number of COVID-19 deaths. They've got 3,405 deaths. China continues to have the most reported cases of 80,967, and Italy is second highest with 33,190. So far a much higher death rate in Italy, which most people are attributing to the age of the population there. In terms of U.S. response to the virus, so I'm sure most of you heard that California has issued a statewide stay-at-home order. We're likely to see this occur in other states where there's community-based transmission who are on the upward slope of the curve. Those are to include Washington and New York, but obviously nothing has been officially announced. I wouldn't be surprised if that's announced soon. The White House has also given over control or leadership of the national response to FEMA. And the White House Coronavirus Task Force Coordinator just recently reported that 11% of all COVID-19 tests performed in the U.S. have returned positive. So that would suggest that we're getting a lot of people who are concerned about COVID and presenting very similarly with other viruses rather than COVID, or it suggests that our tests are not very good. One of the two. Hopefully it's the hopefully it's the fact that we're still in flu season. Cold and flu season is out there. So unfortunately, it's hard to know whether your fever, cough, and shortness of breath is from COVID or from another viral illness. Interestingly enough, the School of Medicine at Mount Sinai also started developing an ELISA test to look for basically antibodies to COVID-19. This is huge because it will allow us to find out if people have been previously affected or infected by the virus, by the SARS-CoV-2 virus. Right now, our tests only come up positive if you actively have the infection. So, 14 days or sometimes less after the infection, you are no longer PCR positive. So the standard testing we're doing is not going to be positive. Eventually, we're going to need to know whether people have had it previously or not, and that's what the serological testing will be able to do.
And my impression on this too, Mike, is that this might indicate immunity. Then, if you have already been infected, then your risk of reinfection could be smaller. We'll talk about that a little bit later. But this could also maybe present as a gateway for a potential treatment option down the road as well. if we're able to kind of isolate the antibodies that are involved, that might be something that someone smarter than me is looking at as far as an option for treating this disease.
Yeah, and I think it's going to be important for assessing vaccination validity and success, as well as just figuring out where we are, where we're standing in terms of herd immunity.
Yeah.
So updates for our patients today. So good news, we just got in a fairly large number of swabs. We have been working off sort of a limited number of swabs for the PCR test. We got a large shipment in today, so we'll be more easily able to fulfill requests from patients to get tested. And then updates in the literature. Lots of new articles out today for us to talk about, Mark. One of the first ones I wanted to ask you about was this pre-pub article that came out on March 17th. Talking about chloroquine and hydroxychloroquine. So lots of interest in the media and in the news about chloroquine and hydroxychloroquine. Trump even mentioned it in one of his recent speeches. I can't remember if it was yesterday or the day before, as a game changer, quote unquote. While I'm not sure it's a game changer, this literature looks pretty reassuring. Tell us about it.
Yeah, I think I'd agree with you. I think I would preface our conversation with the kind of disclaimer that this is a small preliminary study. So, I think this is encouraging. However, I'm not sure this is going to be what we end up settling on. And I'm sure that as far as treatment options go, things are going to be evolving in this space really quickly. But this study was out of Europe, and it was a study that enrolled 36 patients. They put 26 in a treatment group, 16 in a control group, and they were treating patients with a combination of the hydroxychloroquine and azithromycin, and then measuring viral load. And so there's a couple graphs that we could probably include here in the notes as well, but they showed a significant decrease in viral load starting on day 3, but then by day 6, the viral shedding was significantly lower in the hydroxychloroquine with azithromycin combination group. So I think this is certainly encouraging that maybe some of the medications we have available, and hydroxychloroquine and azithromycin are generally well tolerated and fairly commonly used medications that have been around for a long time. They're usually pretty easy to get, and as far as I know, they're not something that has a shortage currently. So having a cheap and maybe effective treatment to even decrease viral shedding can be something that maybe we need to look at. And this is something that I guess I'm not sure where you are with this, Mike, after looking at this, but after seeing this literature, I think if I were to develop symptoms, I'd probably be treating myself with this treatment regimen that they described. And I've even started presumptively treating patients in the ER with this. And not saying that's the right thing to do. I don't know what the right thing to do, honestly, with this disease is at this point, but I think this is kind of the best we have at this time.
Yeah, I think chloroquine and hydroxychloroquine are fairly well tolerated, while there are some side effects, QT prolongation. I think that they've been around forever. We know what they do. And the fact that there is a potential benefit, and this is not the first study to suggest a potential benefit, especially when it comes to progression of disease. I'm definitely using it in my patients currently, and have been considering it as prophylaxis. And I'm actually going to have a PharmD on the podcast. We're recording with her tomorrow, so likely going to come out Sunday morning to talk about chloroquine and hydroxychloroquine. We're going to try to address some issues such as supply and also cost, which turns out apparently before or just around the time that COVID came out, and where the first when some of the first reports that chloroquine was being used came out, there was some suggestion that maybe the company increased the cost of the medication by about 2x, which is unfortunate. But we'll go into that hopefully on tomorrow's podcast. But I agree with you, Mark. I think in terms of what we have available, this is maybe it at this point.
Yeah, I think so, especially for something that's oral and an outpatient regimen. I think my practice is going to be until I see otherwise, and that could be something that changes quickly, but to at least do a screening EKG to look for QT prolongation before starting these medications, just to be sure I'm not giving this to someone who already has a prolonged QT to start with. So that's what I'm going to be doing as far as addressing this. And I think there is some interesting public health indication or implications here as far as maybe decreasing viral shedding and viral load over time to maybe slow down the spread of this disease, which hopefully shakes out to be true in larger studies.
Great. Thanks, Mark. Next article is regarding GI symptoms. So this is regarding people's presenting symptoms or some of the symptoms that they're complaining of when they first get diagnosed with COVID. This was a study that was on 204 patients, all of which who had COVID-19. They basically went back and looked at what their presenting complaints were. And they actually found that 48.5% of them, or 99 patients, presented with primarily digestive symptoms as their chief complaint. Now, these patients, the majority of them also had respiratory symptoms as well, but they actually came in mostly complaining of digestive symptoms. Things like anorexia, diarrhea was fairly common. Vomiting was not as common, and abdominal pain was not as common. So while this is, obviously does not...
To this I say, this just isn't fair. Yeah. It's not fair. Yeah. They shouldn't be allowed to do that. We should group these patients. Yeah. They should all have respiratory symptoms. Because when you're looking at this, man, this just makes it so difficult for those frontline providers to try and screen these. Because to me, that sounds a lot more like flu or gastro, something that would typically be a fairly benign, self-limited condition. And now we're have to think about COVID and all these patients as well. But I think my takeaway from this for those people who are working in kind of frontline positions is that just really use your PPE, and that you can't really trust that triage note or the patient that might have kind of more a GI type presentation initially. It's probably worth using mask and personal protective equipment and kind of treating everyone like they presumptively have COVID at this point is what I took away from this.
I totally agree with you, and that's now my practice. Basically, PPE on everybody. You are COVID until proven otherwise, unfortunately. Yeah, and I don't see a way around that based on this data. Co-infection rates. This is something that is fairly hot off the press. So this was just released yesterday. This is out of a study out of Stanford, and they looked at patients where they performed both PCR testing for viral illnesses. So this is a PCR test similar to the COVID-19 test, where they just run a bunch of different potential viruses. And they compared, they did those PCR viral tests along with COVID-19 tests on these patients who had suspected illness, and they found that somewhere around 22% of the people who had COVID-19 or the SARS-CoV-2 virus also had other viruses. So they were also positive for things like rhinovirus or RSV or metapneumovirus or influenza. This is a problem.
This came out when I was working a shift yesterday. I was in the ER, and this came out hot off the press. We're discussing this with the hospitalist because our protocol had been that if someone had a positive respiratory PCR panel, that kind of made them COVID negative by default. And so I think we can no longer lean on that. So our treatment algorithm and our cohorting of these patients is rapidly changing.
And there's thousands of people that have been sent home with the diagnosis of, we don't think you have COVID because you're positive for this other virus. And unfortunately, that may not always be true. So now we're stuck in a situation where we don't really know what it means to have an alternative virus. You may still have the SARS-CoV-2 virus, and I think we're limited to, now we're just going to have to test people who we're suspicious on, and we can no longer, and at least in my practice, I can no longer lean on a PCR test for an alternative virus.
I don't think so, and I think the other piece of this is that so they had 127 patients that were positive for other viruses. And of those, 9% had a co-infection. So the 49 positive SARS-CoV-2, that was 22% of those also had a co-infection as well. So it kind of goes both directions there when you're looking at patients that have positive SARS-CoV-2, but also for patients who test positive for something else. And yeah, I think I'd agree with you. We can't use that respiratory PCR as accurately anymore to rule out a SARS-CoV-2 infection. So I think the last two articles we talked about, we're just seeing that this is becoming more complex over time as far as being able to not only pick these patients up with any kind of screening protocol or triage protocol based on symptoms, but then also the testing we have just remains kind of inadequate as far as being able to rapidly rule out these patients at this point.
Next study to talk about is one that really goes over sort of the demographics of patients who got admitted to the ICU. So this is a study that came out of Washington, released on March 19th this year, obviously, which was basically looking at 21 critically ill patients. And these are some of the first patients to be treated in Washington State. They found that those people were a median age of 70, but the age ranged from 43 to 92 years. The majority of them had alternative comorbidities, things like heart disease, chronic kidney disease, congestive heart failure were very common. They found that most of these people progressed fairly quickly and had to get admitted to the ICU fairly quickly and developed acute respiratory distress syndrome in most of the cases. The thing that I think is probably most remarkable about the study is that as of the time just before publication on March 17th, the mortality of those people who are critically ill was 67%. 24% are still in the ICU, and 9.5% have been discharged from the ICU. So that's pretty insane to me that once going to the ICU, less than 10% are actually making their way out of the ICU. So once this illness gets critical in people with comorbidities, it's a grim prognosis.
And I think even though the numbers here of the overall mortality numbers are fairly small at this point, that the age breakdown was slightly shocking to me to look at. So when you look at the 44 cases that results in mortality, that 34% of those deaths were in patients over the age of 85, which is kind of what we've been hearing. And then the 46% in that 65 to 84-year-old age range, again, that over 65 being kind of a known risk factor. But 20% of deaths were in patients aged 20 to 64 years old, which is something that I think we have kind of been not really considering as far as younger patients and their overall risk for this disease. Fortunately, there were no deaths in the under 19 age range. So those patients, it seems like, have been spared the most severe effects of this virus so far.
And the study that you're quoting right now came out on March 18th. That's severe outcomes among patients with coronavirus disease, COVID-19. We've traditionally, most of the data that we've seen has suggested that really this is a severe disease in people 60 and older. But this would suggest that there is some risk in younger adults as well, which is clearly concerning.
Absolutely.
All right. Well,
should we
let's answer some questions. I feel like we've been all negative the entire podcast so far. Sorry. We need to talk about something positive here. So maybe we can have some fun with some of these questions. First one is Mark. Do you want to ask the first one?
Yeah. Because I don't know the answer, so I'll ask you, and then that way I don't have to not look smart.
Perfect.
So, is mitigation of the virus possible without a known vaccine? So this is coming off the Facebook, Instagram question.
Oh, okay. So this is in response to a graph that we posted from the Imperial College, which was basically sort of there was a study looking at, what's the possibility in terms of, suggesting that we perform this sort of self-isolation for a certain period of time. And then there's this risk of a delayed bump, and basically making the argument that we need to somehow mitigate the virus rather than just decrease the rate of transmission. I think that's true. I don't think that there is a clear path to mitigation right now. I mean, clearly, in order to truly mitigate it, we need a vaccine or we need a very adequate treatment. I think, chloroquine, hydroxychloroquine has been suggested as a possible treatment. It is clearly not a game changer, and it's clearly not going to, drastically alter the progression of disease in everyone. I say it's clearly not to. The data has not supported that it's going to clearly alter the duration of disease in everyone. So I don't think we can really lean on chloroquine or hydroxychloroquine, and truly we need a vaccine. Whether that's possible or not, I don't think we truly know. Not every virus is really amenable to vaccines. So while it's likely, I think, that we'll find one, it could take some time to really find an adequate one, and the success of the vaccine remains up in the air at this point.
I am I'm optimistic here. I think that maybe if we can flatten that curve, as it's been shown, that just kind of buys us some time to come up with some more effective treatment options and learn more about this disease. And I think we're seeing with the pace of the literature that's being released so far. I mean, I have never seen anything like it as far as how quickly people are working on this, and things are coming out almost hourly that are changing our way that we treat this on the front lines and the ER and in clinic. So, my hope is that we're going to hit on something that then we can go back and validate and prove. And maybe if we are able to spread out the disease burden over time, that we'll have more effective treatment a month or 2 months or 5 months from now.
Certainly, our play right now is delaying the progression of disease, or the rate of transmission at this point. That's our play, while working on everything else in the background. And I got to agree with you, man. I am blown away by the speed at which the research is being published. I mean, even with a team of 10 people that are helping us sort of curate all of this knowledge into these podcasts, it's still hard. It's a ton of information to go through, and I think it takes a village for sure.
It's overwhelming, but I think it's also a good problem to have. I mean, I think there's a lot of really smart people who are focusing their efforts on coming up with treatments and looking at potential vaccines, and I hope that continues. So I think there is some reason to have hope here that we are going to find something that's effective for this, whether it's a vaccine or a treatment algorithm that allows us to at least change that mortality curve a little bit from what we're seeing. So what's your opinion, Mike, on co-infection rates at this point? So I've heard it said a couple times, kind of in passing, a reinfection. Reinfection. Yeah. So maybe I should just go out and get exposed and kind of get this over with, and then I'm going to be safe and move on with things. Is that a good strategy at this point? I guess my impression from looking at the recent morbidity and mortality report is that I wouldn't recommend that to anyone, even if you are a healthy 20-year-old. I think you do have some significant risk, but does that reduce your risk or make you immune to getting this virus again or getting reinfected down the road?
So I'll answer this by saying I'm not a virologist, so this is not exactly my area of expertise. I think that it's my sense is that there is no data right now to suggest that is currently happening. And I think the couple of cases that have been reported where there was this possible reinfection, I think it's unclear whether there was adequate testing in the first place. And then I think it's also going to be extremely challenging to say that there is or is not reinfection when we've got a test where we don't even know the testing characteristics. So we don't even know how accurate our PCR test is at this point. I've heard numbers anywhere ranging from 50% accuracy to 90%, with 75 being the guess of a lot of lab PhDs. So I don't know. I don't know the answer to that question. I think that it's probably unlikely, but I think we probably need to get a virologist on the podcast to truly answer that with any accuracy.
And that not knowing those testing characteristics also really plays into how we interpret the rest of this data as well. I mean, because when you're looking, especially that study that we had that was kind of small on the risk of co-infection of SARS-CoV-2 with other respiratory pathogens, I mean, it could shake out that, that number is quite a bit lower than what we expected. And it's just a characteristic of the test that we're not accurately characterizing. Either we're not sensitive enough or specific enough to pick up those COVID cases of people that actually do have co-infection as well. So I think, a lot of questions are going to be answered hopefully pretty soon here once we have some better testing data back and have another couple testing options potentially as well.
I've got another one here for you, Mark. I'm gonna go off the list here for a second because I'm actually getting active text as we're talking, and a provider that we're friends with asked me what we think about using UV light to sterilize the mask for reuse because they're running out of PPEs.
And I got to tell you, I don't know if I can make a educated comment on that. I think we're in a really tough time as far as being short on PPEs. In my mind, I think trying UV light probably is better than trying nothing, but I can't, without doing some digging on this, give you a real answer to tell you that's going to be a safe way to clean your N95s between shifts or between patient encounters. What's your thought?
I have no clue. I have no clue. I will tell you that I have been putting my N95 outside in the sun in between shifts in the emergency department. But do I have data on that? Absolutely not. I have zero data on that. The other thing I have been doing, which I think is actually probably a decent idea, is wearing a surgical mask over the N95 in case anybody...
I've been doing that as well.
In case anybody coughs in your face, you'll theoretically extend the life of the N95.
Sure.
So in any case, all right. Next question, Mark. Someone asked what we think about iodine for sterilizing coronavirus. Any efficacy there?
So I looked into this a little bit. There's a few data points out there. The European Center for Disease Control put out some recommendations after the European outbreak, and they did say that iodine was effective. I think ethanol is preferred. 70% ethanol is the concentration that we're typically looking at. So that's what I'm usually reaching for. And maybe some thoughts that chlorhexidine is potentially not as effective. So the wipes that we have at the hospital typically contain a high concentration of ethanol along with some other antivirals, antibacterials in those as well. And that's going to depend on kind of where you're working and what you have access to. If you're at home, there's stories of people making their own ethanol solution, either using kind of commercial grade alcohol or using Everclear from the liquor store, which you could also consider as well if you're really kind of stretched as far as being able to get a hold of disinfecting wipes or hand sanitizer.
Finally, something to use that Everclear in your cabinet for. All right,
it's a lot better use than the other.
It's certainly a better use, especially right now. Okay, so last question.
All right, I think last question.
Yeah,
I'm going to ask you this one because I think it's a tough one.
Okay.
So, how to best address the IL-6 surge and cytokine storm that we're seeing associated with the COVID infections? And then talking about steroids potentially, and is there an increased risk with nebulizers and inhalers with reactive airway disease, as far as, I think they're saying hyped up immune response, but maybe just increasing that sympathetic tone related to those medications?
I don't know that I truly know the answer to this question, and I'm not sure the answer to this question is knowable at this point. I think that we don't truly understand exactly how this virus is causing the progression to disease, where you get a acute respiratory distress syndrome, whether that is related to the inflammatory reaction that your body is creating, or whether that's primarily from just the infection from the virus. I think that's unknown. We've spoken previously on the podcast a little bit about how angiotensin II could possibly be related in the development of ARDS, or acute respiratory distress syndrome. We also spoke briefly, I think either yesterday or the day before, on the use of steroids and anti-inflammatories in the virus. Basically, the theory being that early on steroids probably blunt your immune response for fighting off the initial aspect of the illness, but once you have progression of disease to more severe illness, there was that Chinese study that suggested that the sicker patients may have actually performed a little bit better on steroids, which could be it could suggest that there is some sort of inflammatory response that is at least part of the etiology of the ARDS. I just don't think we know.
Yeah, it just makes me wonder. I mean, I think we're probably looking at this disease. We're probably taking a kind of overly simplistic view at this point, just because we don't really have the data to know what we're dealing with. But I'm sure there are different facets to this, where the sickest of the sick patients are going to develop that almost sepsis picture with the cytokine storm, the ARDS, that have a significant inflammatory component, where maybe vitamin C or steroids or the sepsis treatments that have been explored might be beneficial, whereas people with more mild disease that don't have that, steroids could potentially be detrimental. And I agree with you. I think it's just, it's yet to be seen. I don't know if we can make recommendations at this point based on the data we have.
I think that's true. All right. Last question. One more. What are your thoughts on continuing versus suspending ketosis diets or intermittent fasting for maximum immune function during COVID-19?
Yeah.
This is a good one, and we've been getting this from a lot of patients. Mark, do you have any thoughts? I certainly do.
So I think I'll touch on the intermittent fasting thing first, because that's something that I was pretty hot on for a while and recommending to quite a few patients, and doing personally as well. And I backed off on that a little bit. I think there may be some data there showing that in that refeeding period, you could have a boost in immune system function. But I do think it is a physiologic stressor, and maybe that's what some of the benefits we're seeing as far as time-restricted feeding or intermittent fasting has to do with, that stress and the autophagy and then the refeeding that comes after that. And at this point, I don't know if that's beneficial if you are potentially faced with either avoiding or fighting an infection. So what I'm personally doing is avoiding kind of caloric restriction. I'm not recommending prolonged fasts at this point. And I think I've backed off a little bit on the fasted exercise part of things, which was a pretty big part of what I've been doing in the past as far as training. So I backed off on that a little bit. So how about you? What are your thoughts on the time restricted feeding or intermittent fasting at this point.
I think we're 100% in agreement on time-restricted feeding and prolonged fasting. I think right now is not the time for prolonged fast. I think that it's probably not the time for caloric restriction. Time-restricted feeding, I kind of go back and forth on. I think it's probably not a great time to initiate time-restricted feeding.